Good morning, everyone. I see people coming into the session. I'll probably repeat this again, so bear with me if you were here early. We're just going to give folks a minute to connect to audio before we get started with the webinar. Welcome. Okay, I see the numbers rolling in. Good morning, everyone. We'll give it 30 more seconds before we go ahead and get started with the webinar. Welcome, everyone, to this NASHB webinar. Okay, we'll go ahead and get started, knowing that folks will be joining the webinar. For everybody's benefit, just to let you know, this webinar is being recorded, and both the slides and the video will be posted to NASHB's website. So yes, I'm going to preemptively say yes, you will have access to the slides. And we're really delighted to be able to share this information with you all today. I'm Sandra Wilkness. I'm the Senior Director for Behavioral, Population, and Public Health at NASHB, and I'm joined by my colleagues, Nia Denise Gooding and Megan D'Alessandro, who support our work in this space on the community health worker side. And we're also joined by our aging colleagues, and that team is run by Wendy Fox-Grage, who may join us in the Q&A portion of the discussion today, as it makes sense. And we're really delighted to be able to touch on this topic: community health workers and family caregivers, opportunities to enhance connection with community resources for aging population and families, and to bring together some folks who are living and breathing and implementing these kinds of approaches on the ground for you to learn today what opportunities are out there and where we may build in this work. So really want to focus the discussion on these innovative strategies that state and local partners are using to connect older adults and their family caregivers to needed services and social supports in their communities via partnerships with community health workers, promotores de salud, and community health representatives. And for the purpose of today's webinar, I'll just refer to folks as community health workers, but please understand that they're referred to in different ways in different communities, and we want to acknowledge that. And we think this discussion comes at a critical time, given the vast and growing number of people providing informal support to aging family members, who together must navigate complex health and social support systems, whether it's the individual themselves or in collaboration with family members who are trying to provide those supports. And this is really born out of many years of work by our colleagues here on the aging team at NASHB and many others with whom they partner. And one outcome of that work is the national strategies to support family caregivers. I just want to highlight that for a moment, say two things about it. My colleague has dropped the link to a recent report from that group in the chat. For those who are less familiar, you can peruse that. Some of you may be very familiar with it, so I'll just very briefly say two things. That strategy was developed with extensive input from family caregivers, the people they support, and a variety of national, state, and local experts and partners who do the work on a day-to-day basis. And the focus is to support family caregivers who provide the overwhelming majority of long-term care in the United States, so they have the resources they need to maintain their own health, well-being, and financial security while providing crucial support for others. And a lot of this happens in partnership with state and local entities and other providers, which we'll hear about a little bit today. And I'd also just like to note that, not surprisingly, a key opportunity surfaced for this work, which is the acute need to assist family caregivers in identifying and developing connections to essential services and social supports in their communities. And this requires an understanding of the unique terrain of each community and how and where to access those resources. So one aspect of building on this work is the opportunity to partner with community health workers This could be a major strategy to address the gaps. In fact, there's a lot of state activity to reimburse community health worker services through Medicaid and to otherwise more robustly partner with community health workers as connective tissue in what we're trying to achieve in healthcare and improving health outcomes and access for people across the country. And as this audience likely knows, or many folks on the line, community health workers play multiple roles in their communities as health and social systems navigators, coordinators, and stewards of activities to connect folks to the services and supports they need. One thing that's really important to highlight for those less familiar, being of the community they serve means they're embedded in the community's culture, needs, and strengths, which brings a powerful lens to this work. So today's webinar is really an opportunity to highlight some of the work that was published in a paper earlier this year, which we'll put in the chat as well and will be available to folks after the webinar, where we try to understand where there's connective tissue between this movement with supporting and sustainable strategies with community health workers and the work being done robustly to support people in the aging space and their caregivers. Really figure out how can we connect the dots. And I will say, we've learned a great deal through research on this paper, and there's a lot of room to continue to move. One thing I'll flag for you, because I don't want to spend a lot of time providing background here, but I think you can get a lot of background on community health worker policies, state policies across the country from our tracker, which we just updated and my colleague popped in the chat. This is a 50-state tracker, which includes context on how states are defining what a community health worker is, how certification and training is supported, and how these partnerships are developed, in addition to really what is the Medicaid strategy and other funding strategies in the state. So I refer you to that tracker for a lot of information, and we're also happy to answer questions that follow up. Okay, so today we're gonna hear from 3 different groups of presenters from across the country with their Thank you. From their examples. And before I hand it off, I just want to say we sincerely thank the John A. Hartford Foundation for supporting this work. They support a lot of work on the aging side of the work at NASHB, and also really saw the value in, first of all, connecting up with some experts on the call today, but also supporting this work. So we thank them. Okay, so that's my spiel on the context. Happy to provide more details in Q&A as we go forward. But let me go ahead and get to the folks we really want to hear from today. We're going to start with our colleagues in Wisconsin, and we'd like to hear first from Phoebe Hefko, who you can see there, it's on the slide, is the ADRC Program and Policy Unit Supervisor at the Bureau of Aging and Disability Resources in Wisconsin, who is partnering strategically with the other 3 presenters we'll hear from Wisconsin this morning. Jennifer Jaco, who's the director of the ADRC of Barron and Rusk counties. Tracy Fisher, who's the director of the ADRC of Dunn County, and Lynette Gates, who's the director of ADRC of Jackson County. Okay, without further ado, let me hand it over to Phoebe to share their wisdom.
Good morning. So great to be with you here today. We're really excited to share our takeaways from piloting a community health worker model in rural Wisconsin Aging and Disability Resource Centers, or ADRCs. I am going to be kind of breezing through my section, but just want to provide some context, and then I'll be turning it over to the 3 Aging and Disability Resource Centers in our area, in our state that tried this out, and every single one of them came back talking about how much that this added to their ADRC, how it strengthened their ability to reach community members that they had trouble reaching elsewhere otherwise. But you can go ahead and move to the next slide. A little background. So first of all, I just want to say that in Wisconsin, we do have these local ADRCs with sites in every single one of our 72 counties, as well as program specialists that are dedicated to serving the 11 Native American tribes in our state. So these agencies really are embedded in communities And they focus on helping people, older people and adults with disabilities, understand their options, the services and supports that can help them remain independent in communities. And our funding comes from state grants as well as matching funds from Medicaid administrative uh, funding at the federal level. Um, in 2022, we got a wonderful funding opportunity from the CDC that was intended to help states address health disparities and increase community resilience in the wake of the COVID-19 pandemic. Um, COVID-19 vaccine uptake was lower in rural areas. And in Wisconsin, rural areas, the population is often older proportionally from other more urban areas. And older adults and people with disabilities, with chronic health conditions, were most vulnerable to the pandemic, to the disease. So we decided to try out a community health worker model using trusted messengers to reach people in rural communities and help get them connected with local ADRCs. We offered a grant opportunity. And we were so grateful to have these three ADRCs who were willing to pilot this model. Next slide. Um, One of the things that we offered to the ADRC staff participating in this grant was virtual training um, for community health workers. Um, this was provided by an agency, Milwaukee AHEC, which has a developed training program to support community health workers throughout the state. And they received intensive training for these new community health worker positions that were established at the ADRCs. Next slide. And this is sort of the range of topics that were covered, core competencies for community health workers. Next slide. And let's see, is there anything else I wanted to say before we get going? I guess just a couple more things. So um, our ADRCs are sort of come from the realm of helping people access public benefits that can support them. We don't focus specifically on reaching caregivers, but that's definitely one of the target audiences. So our projects were not specifically focused on reaching caregivers, but we certainly did reach both caregivers and people in need of care. Um, and we do that on an ongoing basis. Um, ADRCs are all tasked with doing a community marketing and outreach in general. That's part of their contract responsibilities. Um, and we do always strive to make sure that community members know us before they need us. But sometimes it can be challenging to reach certain segments of the population. And so community health worker model helped us to do this. Each agency that's about to speak with you took a slightly different angle on how they would use the community health worker in their area, which audiences or target groups they were looking to reach, and they'll tell you more about that. Um, and with that, I'm going to turn it over to Jennifer Jaco at the ADRC of Barron and Rusk counties to share a little bit about their project.
All right, good morning, everyone. I'm Jennifer Jaco. I'm the director for the ADRC of Barron and Rusk counties. And you can go to the next slide. So our focus, one of the reasons we had interest in employing a community health worker was we saw significant increase in our home delivered meal program. So you can see from 2018 to 2023, we saw a 43% increase in meals delivered. And so while we do employ a full-time home delivered meal coordinator who focuses on eligibility of that program and then continuing eligibility, and then also provides some limited information and assistance to those customers, we felt like we had an opportunity to utilize a community health worker who could work with some of our more high-risk customers within that program. Next slide. And so what we decided was maybe criteria of a high risk focus for a community health worker. And actually, I should back up a little bit. The individual that we ended up employing as a community health worker was actually a retired nurse within our community. She had worked with a local healthcare system for over 35 years, and she really understood a lot of our local resources. And so that was really valuable to us. She did go through the AHEC training, and she felt like that was a huge support in the work that she was doing. But because our counties in northwestern Wisconsin are very rural, having somebody come in understanding a lot of the local resources, because those can be quite scarce in some areas of our counties, was really important to us. So what we wanted to do was focus on individuals who were living alone, with memory concerns or no supports. And where caregivers come into this, a lot of times we have some very long distance caregivers who might be living in other states, who are utilizing the home delivered meal program as a way to make sure there's some supports and wellness checks for their loved ones. So we recognize that. We also worked with people, maybe with couples, both living with memory loss, and or people who were recently discharged from a hospitalization or a nursing home. And so we did focus on those high-risk individuals. Our home delivered meal coordinator would make referrals to our community health worker with individuals that kind of fit this area, and she would work with them for about 90 days. Next slide. I wanted to share, ultimately this was extremely successful for the customers that she worked with. We do have some data to share from you. I will make it quick, but for the initial first 82 customers, she would complete memory screens. She would complete the PHQ-9 depression screening, and she also, before and after the 90 days, and she also completed the enhanced determined nutrition assessment, pre and post. And as you can see from the data here, significant improvement when working with a community health worker. Next slide. I just want to make sure that I keep within my time here. I won't read through this, but she had several success stories. She was able to link those higher risk individuals with the supports and services. And throughout that 90-day period, checking back in with those individuals on whether they needed follow-up or they needed assistance. The most most typically those resources that she was connecting them with were transportation, additional nutrition, and maybe in-home help. So I won't read the success story, but I just wanted to make sure that, bottom line, everybody knows, in utilizing a community health worker within our home delivered meal program on those higher risk individuals, we really saw a huge impact. The data shows that impact, and those people that she was able to provide more intense support during that time to make sure they had what they needed to, age in place. We really saw that result, and we would, if the funding were there, continue that position in that program. And next slide, I will pass it on. I kind of shared this slide. I got ahead of myself. I'll pass it on to Tracy.
Thank you, Jen. I'm Tracy Fisher. I'm the director of the ADRC of Dunn County. And thank you to this group for having us present today. It's very honored to be able to provide this info. Next slide, please. So in Dunn County, we identified our biggest need in terms of connection with members of the community to be connection with the Hmong community. That was our identified need when we wrote this grant. We are a rural community with a population of only about 46,000, and Hmong residents make up our largest minority group, about 4% of our population. Next slide. So our project of the three Wisconsin projects presented today probably takes the most traditional approach. Alita, who was our community health worker, is of Hmong descent and is bilingual. She has a lot of connections with the Hmong community. She also had a lot of lived experience in terms of navigating systems throughout her whole life. As a child, she helped her parents navigate systems, and that has continued through her whole life. And our grant project, our project really focused on building community connections and strengthening our relationships within the ADRC and other county resources with members of our Hmong community. So next slide. We had a few areas of focus when we went into the project. Prior to COVID, we had an active group supported by the ADRC called the Hmong Friendship Group. And it really fell apart during COVID because it was not an easy group to maintain in a virtual format. And that group provided a source of connection time, activity, social support for Hmong elders in our community. So one of our primary goals of the program was really to reinvigorate and re-energize that group, restart it. That's something that Alita was able to do very, very well. That group started when we kind of had our first meeting. We had about 8 participants, and now we have anywhere from 50 to 70 participants at each session, which is a huge number for us. We also, through Alita's work in connection with our local food pantry, our Hmong Friendship Center time has become a pop-up food pantry source for our local food pantry. Our local food pantry indicated to Alita, that they were having difficulty serving the needs of Hmong folks in the community, especially elders. They weren't seeing folks utilize the pantry, even though there was indicated need. And what Alita found out is that there was not a lot of foods that members of our Hmong elder community were very interested in using. And so she worked with the pantry, and they now stock a different selection of foods than they previously had, as well as actually providing those foods at the actual Hmong Friendship Center directly to the elders. So that it makes it a lot easier for them to access those services. We've also become a pop-up monthly meal site for our county nutrition program, and the elders actually choose the menu themselves for that monthly meeting. And we work with a local Asian restaurant to cater that service. So that's been amazing. Alita has also made a lot of connections with our medical community, with our public health agency. Our local hospitals and clinics make direct referrals to her, especially for folks that they have concerns, might not fully understand their discharge instructions, or might not understand their follow-up appointment schedule. So Alita has been great with that. She's also become a great resource for some of our housing agencies in our county, and actually some landlords that were perhaps having some communication issues. Alita has intervened and, in fact, changed the course of some situations that likely would have ended up in evictions, just because of lack of communication, lack of understanding. So she has really worked her way into multiple levels of our existing services, and it's been really neat to see. Next slide. So our lessons learned is that our CHW was invaluable in complex situations. She teamed with people quite frequently and had more time to spend than some workers in more traditional roles. One of the things that we definitely learned is that we have a lot to learn and gain from members of the community. I neglected to mention in a slide before, one thing that was really interesting is when Alita's kind of services became known, some of our other human service agencies in Dunn County started to lean on Alita. One in particular, a family and children's unit worker, said, I'm really struggling with this family. Their children are constantly truant, and we're really having a hard time getting through to them. Is there something you can do to help? And Alita said, well, why don't we bring this to not the family's specific information, but this information in general related to truancy to the Hmong Friendship Center group and ask our elders what they think, which was amazing. And when our family and children's section social workers attended a Hmong Friendship Center group and presented and talked about truancy, they actually saw amongst their families that they were working with that had truancy issues a significant decline, because I think what we really learned was how much the elder viewpoint in our Hmong community is honored. And when the elders understood what was going on and took that information back to their own families, they saw a marked change in truancy rates. And so leaning on the elders and the members of the community to help solve problems was very effective in Dunn County. The other thing, the program will grow once the seeds are planted. So when our grant project started, I kind of worried, like, I only really have one major goal. How is this going to go? But Alita was a real go-getter and was making connections left and right and making her services known. And that once the ball got rolling, it was like there were more things than she probably got involved in more things than we ever would have guessed, just because people saw her value and saw the value of her work. And my biggest key thing to pass on is the right person in the position is key. If we hadn't had somebody like Alita who had that community connection already, was bilingual, and also was herself very interested in the project and very interested in growing the program, I don't think we would have had the level of success that we did in Dunn County. So though I believe that's my last slide, and so I'll be turning that over to Lynette.
Hi, I'm Lynn Gates. I'm the Director of the Aging and Disability Services of Jackson County. And I'm going to apologize right now. I am in an empty meeting room, but the meeting next to me is getting quite lively, so I'll apologize if there's any background noise right away. Jackson County, you can go to the next slide. Jackson County used our CHW more as a case manager for clients that were not kind of falling through the cracks or weren't fitting into any of our other programming that we had in-house. Either they didn't rise up to a need for adult protective services, but there were still concerns for them. They maybe at this point didn't qualify for long-term care benefits. Community members, family caregivers had concerns about them in their homes. So we got referrals from many departments in our Health and Human Services building, and worked with our CHW on sometimes very quick, easy solutions, and sometimes working with those clients for months. Next slide, please. So it's care coordination, case management, navigating some of the systems, making referrals to healthcare, making referrals for transportation, making referrals for getting lifelines, helping clients maybe get new phones, so that they had some kind of a connection. Another big part of our CHW is she worked with our evidence-based programming and our public health department in bringing people in for things such as Walk with Ease, or new bingo size exercise program. She was also a big part of our social isolation and loneliness work in the state of Wisconsin, piloting some of their programming and resources. Next slide, please. So again, making referrals, hooking up people with other community systems, working on social isolation. Another big outreach that we had was working with some cases and community partners on some hoarding issues with clients in their homes. It's a big issue, especially in rural areas where hoarding may have been going on for years and years and years and no one realized. So building those bridges and trusting relationships with clients takes a lot of time and care. And so sometimes spending, 3 or 4 months building up to maybe finding a solution. It might not be the best solution or the solution that everybody else wants, but maybe a solution that works. Our CHW also continued to do many, many outreaches in 2024. I think our ADRC unit with our CHW help did over 70 outreaches in our community in 2024, trying to get out our services, our programming, making people aware of who we had and how we could help, and advocating for individuals. Next slide, please. As I said, we worked with our public health unit on providing some health promotion, disease prevention programs. One that isn't on here is that we also did the Step with Ease, which is a fall prevention program. So that is part of our focus and will continue to be part of our focus, is still doing health promotion. Next slide. This is just a picture of one of our bingo size events, which has gone over really, really well in our community. One of our goals for aging in 2025 is to take this program virtual. And so we are doing our first session virtually to try to reach more individuals in our community that are very rural and isolated. So we're very pleased with how that is going, working out all the kinks the first time around. Next slide, please. Some lessons learned is that we really, a CHW really needs to set boundaries, learning not to give out personal numbers, working normal office hours, learning that you sometimes can't help everybody right away, that sometimes you have to walk away and come back. That getting in the door the first time might be your introduction the first time around, and a month later you may get an opportunity to reach out again. And each time you're able to make that connection, it gets easier and easier and more trusted. And so a lot of the clients we work with don't trust a lot of people in their lives. And so building those bridges sometimes takes a long time. And having a CHW allowed her to spend more time on a specific client, where most of our other programs, they just don't have the time to spend the time needed to make some of those connections and help. Next slide, please. That's all I had, I guess. Thank you.
Wonderful. Thank you for these rich insights. Really appreciate it. It's great to have data and great to have really the stories that wrap around, right, these very human interactions and needs. I really appreciate it. We did have one question in the chat. Folks can pop other questions in the Q&A section of the Zoom meeting if you have other questions. And Jenna, I see you have a question here. Would you like to open your line and ask your question?
Hi, can you hear me?
Yeah, gotcha.
I felt like the lady who was just speaking was referring to her Hmong CHW as like not there anymore. So I was just trying to figure out, like, did they lose funding or did she just leave, or like what happened?
So our funding was pulled temporarily in March. We've gotten it back. She has taken another position, so she's doing both duties right now, as the funding will be done at the end of May. So she is transitioning to a new role in our ADRC, but we're still using her when we can as a CHW.
Thank you.
Wonderful. Thanks so much. I appreciate it. Any other questions in the Q&A, please go ahead. I think I'll just follow up with a quick question before we lose this sort of collective impression of what you all have done. And funding is a big issue. And as I think was noted at the beginning, there were some public health CDC funding sources that were supporting some of this work from the public health side, community health worker services and supports. And we'd love to hear any thoughts you all have about continued funding for these individual positions or for opportunities to build on these kinds of partnerships. Phoebe, go ahead.
Yeah, I wanted to say something about this. First of all, as I mentioned, yeah, we did have limited term grant funding for this to try this. However, after we saw the impact of um, being able to utilize this model, we realized that this was generally applicable and probably not just in rural areas, but really in any aging and disability resource center service area. So we have modified our standardized grant award expectations for ADRCs to permit them to use the state and federal funding that they receive to staff a position like this if they are able to figure out a way to budget for that. Now, it can be a bit of a challenge. ADRC budgets can be tight, but we want to allow ADRCs to really truly consider this and have the flexibility to incorporate a position like this if they can going forward. So we'll continue to promote the model.
Thank you, Phoebe. That's really helpful. And I know that on the ground, the ADRCs and other providers, partners often have to cobble together resources from different types of infrastructure, different types of funding. And I wonder if anyone in the group wants to talk a little bit about how you did that. How did you forge those partnerships? Because the CHWs often come from a public health space. And how do you bring these worlds together? Any wisdom you can share on that front would be welcome.
I guess if you don't mind, I'd like to just share that we were so successful, I think, in our human services, showing our community health worker and how well she did, that we now have 2 other community health workers in other programs in our human services building. So even though we may not be using our full-time anymore, we do have 2 others in our building that are loving the model that we showed them. So it was a great chance for us to open the door. And then we have 2 other ones in our rural community outside of our building. So not only was it great for us to bring the model in and show everyone else, but I think they've seen the success of it, and so now are funding their own. So public health has one of their own right now, and then Family Promise in our building has one of their own. So I think that's been very successful also.
Great. Thanks, Lynette. Tracy and Jennifer, anything you'd like to add?
I would also add, like Lynette, the fact that we were able to do this as a pilot, kind of show the effectiveness. In addition, our public health department also had a community health worker. We did also have another entity in our service area. It's a federally qualified health clinic. Start a community health worker position. So that was, directly related to the successes that we were having reaching individuals, and they wanted to do that. So yes, we are seeing more access. If we can't employ them, maybe somebody else can, related to the funding. In terms of funding, I, still want to keep that as an open idea within our agency. Right now, kind of looking at the state and federal budgets, I'll have to kind of wait to see, but we have some good data to show the effectiveness. So maybe even further down the road, if funding is looking better in our agency, but it's nice to know we've got another agency that we can make referrals to as well.
And I would just share that in Dunn County, at least, we already had a very positive working relationship with our public health department, which is ongoing. And they were very, very interested in the CHW model and are still interested in looking into the CHW model for work specific to the health department. So they really have been involved and supportive of the project from the get-go, and have been a wonderful partner to work with.
Terrific. Thank you all so much. And as the only other thing I will add to this is, as I think was noted earlier, the community health worker in the Hmong community really reached out into other areas of need and support, like housing, and it may also open the door to other partnerships and other potential funding streams to support these positions. Thank you all so much. Wisconsin, you're getting a shout out in the Q&A from Molly Wisniewski, who's talking about how dynamic your approaches are and is grateful. So we are grateful as well for your for your work and for sharing with us today, and appreciate it. Please stick around if you can for Q&A at the end. And at this point, we'll move on to hear a little bit about what's happening in Texas. We're going to hear an overview of CHW training and providing age-friendly care to older adults in Texas. Our presenter is Denise Hernandez, Assistant Professor of the Public Health Program in the Department of Kinesiology. Sorry, that was not easy for me to say. Center for Innovation in Health Informatics at the University of Texas in Arlington. Denise, if you're with us, I'm going to hand it over to you.
Thank you so much. Yes, thank you for letting me join you today and present on the work that we've been doing over the last couple of years. And one of the reasons we've been able to do this work is thanks to the John 8 Harper Foundation as well as the National Rural Health Association and their support for this project and their belief in the CHW model. This training that I'm going to be discussing is one that was developed for community health workers who will be working in programs like the ones that were just shared. And so hopefully we can see the connections and how we can continue to build those partnerships. And so again, the name of the training is Providing Age-Friendly Care to Older Adults. Next slide. And before before I start, I do want to share, and actually, I think you're missing a couple of slides, but that's okay. I believe there's a understanding here of what the definition of community health workers is. And so, according to the American Public Health Association, a community health worker is a frontline public health worker who's a trusted member of the community and has an unusually close understanding of the community served. And so, I believe everyone here already has that underlying understanding. Research does show that community health workers increase health-related knowledge. And can you go back to the last one? They increase self-care practices and health outcomes, increase screening rates, facilitate behavioral change by providing encouragement, support, and serving as role models, and have been effective in high-risk behaviors in target populations. There's been hundreds of studies that shown that CHWs are effective in reducing high-risk behaviors and increasing health-related knowledge. And so we know the model works. In Texas, next slide, and I'm going to share a very brief background on how the CHW certification model works in Texas because our state representative wasn't able to join us, and that's okay. And so just giving you a little bit of background. Texas was the first state to pass legislation creating a statewide training and certification program in 2001. Next slide. To become certified in Texas, you do have to live in Texas, be 16 years old. So that was changed in 2019. It used to be that you needed to be 18 years old. And so now we're seeing the training being implemented in high schools and being offered to students as an alternative to, not everyone is ready to go to college right out of high school. And so this is a great alternative to continue to serve their community. The training, you do have to complete an approved DSHS certified 160-hour competency-based training program, or you can become certified based on experience. You have to have at least 1,000 hours of community health worker service in the recent 3 years, and they do verify your experience. And we do have to renew our certification every 2 years. And by doing that, we have to complete 20 hours of continuing education. So 20 hours of continuing education every 2 years so that we stay up to date on health-related topics, updates on anything that's changing, any recommendations that we know that often change for screening, especially screening recommendations whenever we have new like with COVID or measles, things that had been popping up, there's new trainings that come out. And so we want the CHWs to stay up to date. Next slide. So in Texas, we have 8 core competencies. When you take the certification training, you cover the 8 core competencies, how to apply them, um, what skills are included, and how they relate to your work in the community. And so you can see them here. In August, the Texas Commissioner approved an update to the 8 competencies to align with the national roles of community health workers. So we added one more and made some changes to the existing one so that they can align to the national CHW roles and skills. Next slide. So in Texas, we do have in total close to now, this is data from last year, so as of March 2024. As of now, we have close to 8,000, if not over. I'm being a little conservative in my in my numbers. But we do have a little over 8,000 CHWs now in Texas. And you can see here where they are spread throughout the state. They do reside in 168 out of 254 Texas counties. So we're almost covering the entire state. It's great to see that CHWs are now being trained and certified in more rural communities, which we know where there is a high need, especially when it comes to our older populations. Most of the CHWs in Texas are women and minorities. And so again, we've seen a huge increase, especially since that COVID funding came through. There's been a lot of recognition of the value of community health workers as well as more training. And so next. So the training that we developed on providing age-friendly care is certified for continuing education, which means that CHW's existing community health workers can take this training and it'll help them. It'll serve for their continuing education required for their renewal. And so this is a 4-hour training. And if you notice here, we have to identify which competencies it covers. And so 1.5 of knowledge-based communication skills, interpersonal skills, and advocacy skills. We do have it available in English and Spanish because the majority of our, especially border communities, speak Spanish. We always have to make sure we have those available in both languages. And the learning objectives, every CHW training has to have learning objectives that we make sure we meet and evaluate. Are that community health workers will be able to describe the importance of providing age-friendly care, define the 4 M's of age-friendly care and provide examples, and understand how to use the 4 M's to support older adult care. We've also offered pre and post assessments. We debrief after the trainings, and we really have open opportunity for question and answer and discussion and sharing of personal experiences. And so I'm going to share a little bit of what those results have been. And so next. So I'm going to begin by sharing some of the content. I'm not going to be teaching you the content, just want to show you examples of what we're covering. And so we begin by defining what do we mean by age-friendly care, and what are the factors that impact how we care for older adults or the importance of caring for older adults. And so we talk about the demographics, and I introduced the terms, but we really don't use these terms throughout because, again, with any CHW related training that we do, we keep it at at least 6th grade literacy level. And so we don't want to use words that are that may not stick. And so we talk about demography, the complexity, multiple chronic conditions, and the risk for disproportionate harm. We also talk about the importance of health literacy, especially with older adult populations and how that can increase the risk for negative outcomes. We go into depth on the 4 M's, and then we talk about how to incorporate it into their work. Next slide. And so again, just an example of what we talk about with older health literacy, we talk about just how it can impact those health outcomes. And then we really break down what do we mean by health literacy, finding, understanding, processing, and using that information, and how does that apply to older adults. Next slide. We also go through, after reviewing what health literacy is and how it's relevant to older adults, we talk about tips for improving that communication with older adults. And so we give some examples. We go through some of these in more detail and how to incorporate those into the work that we'll be doing. Next. So then we spend some time talking about the 4Ms. And if, for those of you who may not be familiar with what they are, so the 4Ms, what matters, medication, mentation, and mobility. These four identify the core issues that should drive all decision making in regard to the care of older adults. They are relevant to everyone, especially older adults, regardless of the disease, the functional problem, the culture, ethnic, or religious background. It's relevant to all older adults. And so throughout the training, we spend some time breaking down each of them, but also talking about how they interact with each other. And so next slide. And so you'll see here, we take what matters first. And in the next couple of slides, I'm going to show you how we define it, how we reflect on it, we practice, and then we talk about how to act upon what we're hearing from the older adults. So next. And so after we go through each of the, again, we define it, we provide some examples, we do some role playing, we do some self-reflection throughout the entire discussion on the 4Ms, because we want them to think about how it's relevant to their community, how it's relevant to their lives. One thing that we've learned from the CHWs that we've provided the training to so far, it has been that they feel like they can apply this not even just to their work, but to their personal lives, because we all know or have someone in our lives who is an older adult. And so it's really important that we spend some of that time in that self-reflection as well. But then when we go through the self-reflection, the definition, the practicing, we're doing some fun role-playing activities. We then then talk about how it all relates to each other. And so here, this is one of the later ones, but we talk about, okay, how does what matter impact the person's mobility? How does their mentation impact mobility? How does medication impact mobility? And then we talk about, okay, well, how does mobility impact what matters? And so we go through each one and think through it and talk about it. So we really are just understanding the big picture and why it's important that we do cover each of the 4Ms. So next. And then finally, after we cover all the 4Ms, we talk about, okay, let's look at your current work environment. Where are some opportunities to incorporate the 4Ms? Is it when you first interact with the patient or the client? Are you doing home visits? Are like where in throughout your daily routine can you incorporate the 4Ms? What are some opportunities to do to ask what matters, to do some mentation screenings? And then we talk through, okay, how can we adapt that? And this has been really interesting because the day-to-day of community health workers looks very different, especially if they're out in the community. And so this has been really fun getting to have these conversations and doing some journey mapping for the CHWs and their patients or clients, because typically this is incorporated into healthcare system where it's more structured. When we're out in the community, every day can look different. And so this has really been an interesting part of the training when we're talking through what does that look like in your workflow. Next slide. So the trainings we've provided so far, we've done two trainings, well, no, three trainings, two in person and one online. In total, we've trained 125 community health workers. The in-person trainings that we did were in El Paso. We offered it in Spanish, and then the online one, we offered it in English. And so, again, we did complete some evaluations for those. Next. And so just some results. Surprisingly, there was half female, half male, which is great. We typically have more female. They're always overrepresented in anything that we do that's community health worker related. While the training was only advertised to Texas CHWs, as you can see, we had attendees from different states, and those are mostly the online ones. The New Mexico ones, it could have been those from that attended the El Paso training, but the California, New York, all the other states, those individuals attended our online training. Again, even though it was only advertised to Texas, but this just speaks to the power of word of mouth in the CHW community. And so next. We did have a diverse population. Primary languages spoken were English and Spanish. About half of them were Hispanic. So again, not surprised there. Next slide. We did ask who was the community that they served, what was the population they served, and as you can see, most of them were serving older adults. Many of them said men and women as well. We asked if they lived in rural or urban communities. It was about half and half. But again, even though we do see that the majority do serve older adult communities, this was very relevant to them individually, and so that was really a point that stuck with me. Their comments of, hey, we're all heading that direction, and so this is important for everyone. Next. We asked where they worked, and as you can see, the majority were community-based organization or nonprofit organization, which was great because that's really who we were hoping to target with these trainings. We want to incorporate this model of the forum providing age-friendly care using the forums in community settings. Next question. Or next slide. So these questions were in the evaluations. We asked them about the content that was covered, and you can see from pre and post, there was an increase in knowledge for all of the knowledge-based questions. Next slide. Here's some more knowledge-based questions. Again, you can see there's an increase in knowledge for all of those as well. Next slide. And then this one's always key. We asked about self-confidence. How confident are they in being able to use this knowledge and use these skills in their work? And you can see the changes from pre to post. And even though it looks like more agreed pre-test, it's that more strongly agreed increase post-test. And so that's great that we see that. We also saw significant decrease in neutral post-test, but an increase in strongly agree and agree. So that's always great. Next slide. And then asked about knowledge about strategies to provide age-friendly care. Same, we saw that there was a significant increase in strongly agree. Next slide. And then their confidence as that they can play a key role in providing age-friendly care. And we saw a significant increase with strongly agree as well. And no more neutral, which is great. We had one that disagreed, but that's not surprising to always have maybe one or two, a couple of people who still disagree in the post. Next. So here is my contact information. We are still in the implementation phase of this project. And so here in the next couple of months, we'll be providing 2 additional trainings in South Texas. And then in the coming months, we'll be taking this training to other states. And once we gather more feedback, especially when we do step outside of Texas, and adapt it more. This training is being adapted to be offered online as well, and making it available to other organizations or other CHWs who want to provide this training or want to take this to their community. And so, again, thank you for letting me join you today, and please feel free to reach out if you have any questions.
Denise, thank you so much. Really exciting results, and we'll look forward to more. It sounds like coming soon, and really exciting to think about how these skills can be woven into the day-to-day activities of a community health worker, which, as you noted, is so varied. And you're not sitting in a clinic setting, but actually involved in the moment at all times. Very exciting. We do have a question in the chat. Young Kwok, I think is the person. Would you like to open your line and ask your question? And if not, I'll read it. I'll read it out. Okay. Was there a difference in learning outcomes? First of all, acknowledge it's a great program, so I have to start there. Was there a difference in learning outcomes between in-person versus online program? And also, what was the attrition rate and what are common challenges in delivering this training program? Okay, that's a lot of questions. So please, you can take them one at a time if you like as well.
So, as far as knowledge, we are actually in the process of separating out right now. All our data is compiled. And so we will be separating those online from in person to look at the differences in outcomes. We were also asked about gender. And so we want to separate the female and male differences. So, I don't have that answer for you now, but we will be working on that. And so, again, feel free to follow up, and I'm happy to share that information when we have it. As far as attrition, because we've been offering this as a training for community health workers to then take it out into their community, we haven't yet followed up with CHWs, and that could be something in the future. Right now, this project is about developing and implementing the training itself for CHWs. But I agree that we definitely need to evaluate after CHW implements it, hearing feedback, what difference did it make, to go along with our previous presenters as well.
Wonderful. Thank you so much. Thanks for the question. And the time permitting at the end, there's more opportunity for Q&A. So if folks have questions, go ahead and just pop them in the chat and we'll get to them as soon as we can. I also wanted to acknowledge with great thanks that Denise provided some additional slides, which will be available as part of this package on our website, that actually runs through some of the specifics around the training protocol, and I think is really interesting additional information as well. So you'll have that available to you as well for those interested in the training components. So thank you so much. Please sit tight, stay tuned to see if we have additional questions. And now we'll turn to our last presenter, who's also from Texas, to talk a little bit about the impact of Alzheimer's and dementia in their community. And we'll hear from Imelda Aguirre, who's Diversity, Equity, and Inclusion Manager at the Alzheimer's Association of Dallas and Northeast Texas chapter. Imelda, if you're with us, I'm turning it to you.
Thank you. Yes, I'm here. Thank you, Sandra. Great. Well, I'm grateful for the opportunity to connect with you all today and share some information about Alzheimer's and dementia and what we're doing with CHWs. And as Sandra mentioned, my name's Imelda Aguirre, and I'm staff at Alzheimer's Association, the Dallas and Northeast Texas chapter. Our chapter serves over 34 counties surrounding Dallas and including some of those rural areas in East Texas. And I've been with the association for over 6 years. I've learned a lot about this disease, including that it was in my own family and didn't even realize it. My own grandmother had dementia and was never formally diagnosed. And my family thought her memory loss was a normal part of aging. and they all suffered in caring for her, and she passed. And we realized we could have done more. But we also know, as many of you know, working with folks in the aging world, we're not the only ones who experience this. And we understand now that, memory loss is not a normal part of aging. So I have a personal duty to share this information with our communities. But I'm going to today, briefly in the slides that I have, I'll be sharing information about the disease and talk about how we're partnering with CHWs in our Latino communities to help with changing how Hispanic Latino families think about dementia and access help for dementia and Alzheimer's. So on the next slide, we'll move forward. Just so that you know, our mission is to end Alzheimer's and all other dementias. We will see our first survivor, and hopefully it's soon in our lifetime. And we're doing this by accelerating global research, driving risk reduction, maximizing care and support. As we know, Alzheimer's is a public health crisis, and right now there are over 7 million people living with this disease in the United States, and it kills more people than breast cancer and prostate cancer combined. And we'll see more about facts and figures in the coming slides. But just so, and if we go to the next slide, I wanted to make sure, that we're all on the same page for some of these important definitions. I acknowledge that many of you on this call may already know this information, but just so that we're, again, understanding, dementia is a general term for loss of memory, thinking, language, problem solving, and other abilities that are severe enough to interfere with our daily life. And Alzheimer's is the most common type of dementia. So when we think of dementia, the way I like to describe it is think of it like a term as like cancer. Because if you say, I have cancer, well, that can mean several kinds of cancers, right? And dementia can mean several kinds of dementia. It just so happens that Alzheimer's is the most common type of dementia. About 60 to 80% of cases that are dementia end up being Alzheimer's. But we can see we also have vascular dementia. We have Lewy body, frontal temporal. We even have multiple types of dementia simultaneously, and this is called mixed dementia, which can be really hard for doctors to diagnose. If someone has mixed, this means that they can have potentially Alzheimer's and vascular dementia at the same time. All right, so now that we have Alzheimer's and dementia squared away, on the next slide, I wanted to share a little bit more about what is Alzheimer's. Like I said, it's the most common type of dementia. It's not a normal part of aging as we know it. And it's so interesting that age is the greatest known risk factor for Alzheimer's. Once we turn 65, someone who turns 65, their risk is increased. And there's also what we call younger onset Alzheimer's, which it affects people that are under the age of 65. It's not very common, but it does happen. Alzheimer's worsens over time. It's a progressive disease. And unfortunately, there's not a cure right now as we know it. It has stages. So in the early stage, there's mild memory loss, but then in the late stage, you see people that are not able to carry a conversation, or they're not able to respond to their environment any longer. And on average, a person with this disease lives 4 to 8 years, but some have known to have lived to up to 20 years, depending on other factors. All right, and then on the next slide, which is one of the slides that I like to talk about a lot, because this is something that maybe a lot of communities don't know about. In some communities, the risk of Alzheimer's is greater. Studies show that Black Americans are twice as likely as white Americans to develop Alzheimer's, and Hispanic Latinos are 1.5 times more likely to develop this disease. And members of our underserved diverse communities are more likely, as many of us know, to endure poverty, have limited access to quality health care, and also less likely to pursue a diagnosis. Alzheimer's is also very disproportionate impact on women. In the US, almost 2/3 of Americans living with this disease are women. The updated facts and figures, actually the facts and figures just came out yesterday the new Alzheimer's and dementia facts and figures for 2025. It says there that out of the 7.2 million people living with this disease that are 65 and older, 4.4 million are women and 2.8 are men. So this is a huge disproportion for for women, and the association is committed to engaging the underrepresented, underserved communities, as well as ensuring that our communities know about this disproportion. All right, and on the next slide, I wanted to share some statistics about caregiving because we work with caregivers. A lot of us on this call work with caregivers. And please note that the slides that I submitted came out, were done before the new facts and figures were released. So please be mindful of that. The 2025 facts and figures right now, it shows that caregivers provide more than 19 billion hours, valued at nearly 413 billion. Right now, on the slide, you can see that care is valued over 271 billion, but now it's increased. So these are all of the hours that unpaid caregivers are, that we're valuing their care. It's at 413 billion. And the number of Texans living with this disease that are 65 and older, it doesn't have it on the slide, but I want to share that it's 459,000. It's over 459,000 right now, people in Texas. And statewide deaths from this disease are over 10,000. And the number of Texas residents as unpaid family caregivers is over 1 million. So as you can see, this has a huge impact on caregivers, not only physically, emotionally, but financially as well. And we'll see, if there's actually, I don't know if we can share a link for our facts and figures here, but Sandra, I'll make sure that you have it after this call, and then maybe we can share it with the rest of the group. And then the next slide, it starts to talk about what we do for our training for our community health workers. I'm not going to go through all of the signs, but this is a tool that the Alzheimer's Association created to provide early detection for families that are seeing changes in memory loss, but they can't quite figure out if this is what it is. So this is one of the tools that we provide to our community health workers, as well as it's open to anyone else that wants to learn about this disease. But there are 10 key warning signs, pardon me, and symptoms of Alzheimer's, which can be subtle. And we talk in depth about what each sign means and how to learn the differences between what is Alzheimer's and what is considered normal aging. So I just wanted to show you a glimpse of what that looks like. But on the next slide, I talk a little bit more about the community health worker training. All of the Alzheimer's programs that you see here, this is what's considered our core curriculum programs. And they're all peer reviewed, and they've been produced by experts in the field. We've trained thousands of community health workers since 2023. And some of the programs that you see here, for example, are the 10 warning signs. Those are, like I mentioned, to recognize the difference between Alzheimer's and normal aging. The other one that we use is the 10 healthy habits for, or what we call healthy living for your brain and body. This is a risk reduction program that's so important to the community. It's been one of the favorites that our community health workers use, but it trains them on what you can do today to reduce your risk as you age. Some things we talk about are challenging your brain, keeping your brain mentally and cognitively fit, so to speak, eating healthy, exercising, managing diabetes, and how all of those things combined can help with reducing risk as we age. And this is critical because a lot of people in our community think, oh, well, Alzheimer's and dementia, it's an old person's disease. Not so much. We can do things now to be able to reduce our risk as we age. And this is one of the, like I said, one of the favorites the community health workers use because it's not so much focused on the disease itself. The other one we talk about is understanding Alzheimer's and dementia. There's also a new one called the Empowered Caregiver. This one's also in Spanish. It has components that we talk about: communication, care and support services, responding to those dementia-related behaviors, and then dementia conversations. There's real tough conversations in families about dementia. So this program teaches how to talk about, stopping to drive, seeing a doctor, and it's been proven to help families understand how to communicate better with some of those challenging behaviors that we see with dementia. On the next slide, I wanted to share some of the training benefits that we've seen right now with the community health workers. All of our programs are available in Spanish, and we purposely create programs on a monthly basis in Spanish that are targeting the community health workers that speak Spanish. And all of their trainings are offered for free because we know that we have a community that's 1.5 times higher, that is 1.5 times more at risk in our Latino communities. It's critical for Spanish-speaking CHWs to learn this material and to be able to share it and train others. And there's a huge stigma in this disease, especially in our Latino communities. Again, going back to families like mine that think that, this disease is a normal part of aging. So just knowing some of the basic information can be really life-changing and empower some of these families that they're getting the information from community health workers. Pardon me. We've also, trained the CHWs to discern the differences between mental health and dementia, because a lot of community health workers have the mental health training, but the dementia piece is not so it's not so much available as the mental health. And it's so important. The community health workers that have Hispanic, Latino backgrounds, they understand the cultural stigma and the views around this disease, and they really have helped us with finding new ways to reach our families with this information. As I mentioned, early detection is so important. And the reason why is because there are right now life-changing, disease-changing treatments that are giving people with Alzheimer's diagnosis more time and a better quality of life. But to be able to access these treatments, these folks have to be diagnosed and they have to be in the early stages of the disease. And that doesn't often happen it's not happening for Latino families. So to be able to get this information early is really the best way for our communities to have access just like everyone else. And also the Latino Hispanic population clinical trial participation is very low, as many of you know. So the community health workers are trained to understand the importance of the clinical trials and be able to share how to access, what those trials look like on our website. One project I wanted to highlight briefly that's not on here. It's a project that we called Las Poderosas. It means empowered women. We took a small group of CHWs who spoke Spanish. We trained them on three things: the 10 warning signs, clinical trials, and the 10 healthy habits for your brain. And they were tasked to share this information with friends and family anywhere that they were in their community. And within less than a year, they were able to reach over 2,000 people in our Latino communities with this information. And we saw an increase in access to our helpline, which I'll share the helpline in a moment, in Spanish. The helpline is answered in Spanish among other languages, but we saw an increase for our particular service area, and also an increase in accessing the clinical trials website. So, the community health workers are so instrumental to the work that we do. And, we're doing this work along with volunteers who have helped join the fight in ending this disease. But community health workers are, folks that we want to keep at our side because, this is just, as I mentioned, it's a growing public health crisis. On the next slide, yeah, we'll move forward here. Let's go to the next one. As I mentioned, I wanted to share a helpline because if you all are out there in the community and you may encounter caregivers or maybe other families, individuals that are concerned about memory loss or maybe need caregiver support. As we know, there's other resources, but the helpline, wanted to make sure you at least had that. It's a 24/7 helpline. It's available 365 days through the year, and it's not just your average call center. These are master clinicians that are answering these lines, they're giving confidential support and information to people living with dementia. And right now, especially our climate with the Latino community, we want them to feel that this is a line that is not going to report you. This line is confidential and is not going to use your information to, share it. This is, and I'm hoping that, as you know this information, you can also share this with the people that you serve, because it's very scary time for the Latino community to be able to reach out to help, especially when a line is an 800 number. But just know that this is a confidential line. We don't share information or report anybody. And finally, in the next few slides, we're almost done here. The next one, this is a very busy slide, but as a side note, all of our programs, support, and services for families are always free. CHW trainings are free. The reason we can offer these programs is because of the fundraising that we do through the Walk to End Alzheimer's and another fundraising effort we call the Longest Day. But combined, these efforts have been able to provide resources and support and research, fundraising for research to end this disease. So if there's a walk near you, I encourage you to be part of this event. It's continued to help so many families going through this disease, as well as individuals who are, battling Alzheimer's. Okay, and then if you're the next slide, if you're so inclined to help us realize our vision of a world without Alzheimer's and dementia, the association has a variety of volunteer opportunities. You can use your unique talents to make a meaningful impact in your community by connecting with others. You can get involved as a volunteer, your company or group, or if you're just an individual needing help and support, we're here for you through the helpline and through other services we offer. And on the last slide, wanted to end with our vision. I hope that this information was helpful for you and it continues to inspire our vision which is a world without Alzheimer's and all other dementias. So, and the last slide is just a thank you note. So I appreciate your time. And Sandra, thank you for allowing us to be a part of this webinar.
You bet. And thanks so much. And we have a few questions. We have a couple minutes left. Let me pop to the questions in the chat. One of which, and I think we may have lost the person who asked the question, but we will follow up if that is the case. Megan's question is, she'd like to know how CHWs can be more involved with delivering ADRD, I think, education across the state. It's a little difficult because as I understand it, once they're trained, we can't track who's receiving education or any sort of evaluation, which makes it difficult to implement statewide. I do know that some CHW certification and training approaches have continuing education credits available. So that's one way to go. But Imelda, Denise, any response to that question?
Yeah, that's true. There isn't really, I made a note of that because I think that could be something we could start to look into, to be able to have the ADRC as as a way for us to, because right now we're focused on just our core programs, but we do need to, we need to have a better way of being able to track and follow up. Right now, it's because we started this in 2023. We're just really getting our footing in, so to speak. But I've taken note of that, and I don't know if Denise, you have something else to add, because I know that you're working more extensively with CHWs on this front.
Yeah, I think it really comes down to that question that we all have about funding, right? If there's a funding to track to deliver a specific training and track the outreach and the impact of CHWs, then great. I think we can definitely do it. We've partnered with other organizations in the past to do something similar, but it all comes down to funding.
Thank you. And then we just have questions, which I think we can get to. How do you request the training? Is it online or in person? I think this is for you, Imelda. And can you share the clinical trials website?
Yes, the training is both available. Right now, we've had it more virtual because it's region wide. It's for the whole state of Texas. But yeah, I mean, absolutely, we have done in-person trainings, but more they're done more virtually. And I'm happy to share. I'm happy to share the schedules that are coming up with you, Sandra. And then you can
Great.
share them at large if you'd like. But I can put I do have the clinical trial website, so I don't know if you want me to put it
Yeah,
in the
please
web.
go ahead and put it in the chat. If hopefully
Okay.
that will be the easiest way to get it to Teresa
Okay, I'll put
and
it in
others.
the
Great.
webinar chat. Thank
Okay.
you.
Wonderful. Any other questions, please put them in the Q&A. I will start to make sure that I am honoring everyone's time to do a little bit of wrap up, and I will keep my eye on the Q&A here. I just want to say again, thank you all so much to our presenters for the terrific work you're doing and your willingness to take time out of your busy days to share with us and with this group, and knowing that we'll reach even more people than those who joined the webinar. It will be posting this as a reminder, folks, the slides and the video presentation on our website so that you can revisit this. If you have follow-up questions, please feel free to send us a note here at NASHB, and we'll do our best to get them answered, or even try to connect with our presenters for further connection if that makes sense here. Just a couple of quick notes. There are other ways to follow up, both on the community health worker side. For state officials, we have a community health worker learning collaborative that meets on a regular basis, about quarterly, where we talk about all things policy related to community health workers, and happy to follow up on some of what was shared here today. We can share with you our newsletter, and that's a way to find out when these meetings are, but please also feel free to reach out to us over email. We have two other resources. We have a state community health worker policies set of briefs, as well as our tracker, so we think that's a good resource. And we also at NASHB have the RAISE Act Family Caregiver Implementation and Technical Assistance Center resources available. We can pop those in the chat really quickly, but also we'll add them in our follow-up here on what we put up on our website. Thanks again to John A. Hartford. Thanks again to our presenters and all the folks who are really engaged in this work. We look forward to continued conversations and continuing to track the terrific work you're doing. And if there's any one of our presenters, Phoebe, you opened your line. If you have a last word, we'd love to hear it.
I want to just say thank you for giving us this opportunity to share our experiences.
Wonderful. We will stay tuned to what you're doing and make sure we circle back as well. Have a good rest of your day, everyone. Thank you for joining us. Take care.